Good morning, everyone. I will keep the introduction extremely brief because probably more than ever, I want to leave a lot of time, plenty of time to our speaker today and to discussion. It is my great pleasure to introduce Dr. Maria Luisa Gorno Tempini. She's a behavioral neurologist with a PhD in cognitive neuroscience, and that already tells you a lot. She is currently a professor at UCSF, where she directs the language neurobiology laboratory of the Memory and Aging Center. And she's also the co-director of the UCSF Dyslexia Center. As I said, her work and her presentation will speak for itself in terms of how pioneering her translation and research has been, and it keeps on being. As one of the very lucky mentees of Marilu, I'm just going to highlight how incredibly generous and prolific as a mentor she is. She's been fostering for years the careers of many behavioral neurologists and cognitive neuroscientists, and those are two different breeds. So to be able to speak to both and lead both groups, it already tells a lot about Marilu. So the floor is yours.
Thank you, Vale. Thank you for being here, and it's been great already to spend some time this morning and see what an amazing center you have here and see how great Vale is doing. It was hard to see her go, but it's wonderful to see this new face for her and her group. So what I'm going to talk about today is really what started to be one disorder and then end up being three. So I'm going to try to go quickly through all three of them and hopefully convince you that the study of these patients that have these particular neurodegenerative diseases can help improve their lives, their diagnosis, their treatment, and also teach us something about the brain and cognitive neuroscience. So a lot of what we know about language from a brain behavioral point of view, from a neuropsychological point of view, comes from patients with stroke. And what we used to really recognize as the only language network in the brain, the perisylvian cortex, had a lot to do with the anatomy of the vasculature of the brain, because those are the areas that get more often hit by stroke, and patients who have aphasia due to stroke mainly have lesions in those areas. And so we associated those areas with being the language network in the brain. Now, studying different diseases that have different susceptibility for different brain networks really taught us a lot more about the more distributed language systems in the brain. So the first definition in the modern literature of primary progressive aphasia was a pioneering work of Marcel Mesulam in the early 80s. And we have to think back that he didn't have scans for these patients, no MRIs. It was just this clinical observation, really, that described these patients that presented with progressive language symptoms, maybe mainly word finding problems. And that was unheard of, because at that point, patients with neurodegenerative diseases were thought to have progressive memory problems, not progressive language problems. So that was already a revolutionary observation. But in some ways, he adapted and kind of deducted that some aspects of the language disorder in these patients that was derived by stroke. So he assumed that atrophy had to be perisylvian, because that's where the language centers in the brain are. And that pathology, so what actually happened in the brain, the molecular toxic changes that happen at the biological level in the neurons, had to be non-Alzheimer's in nature, because Alzheimer's disease presented with memory problems, not with language problems. And we'll go through 20, 30 years of research to see how he was somehow in some aspects right and some others not. At the same time as Marcel was describing PPA in the US, in the UK, the pioneering work of John Hodges and Carolyn Pattison and and my PhD mentor, Kathy Price, really showed that there were patients with this progressive anterior temporal lobe damage called semantic dementia. They had a progressive loss of semantic memory as cognitive mechanism, but clinically they presented with language symptoms. And how these two disorders related to each other was really the beginning of my interest in this field. Again, about the same times, a little bit later, Murray Grossman, who unfortunately we lost a couple of years ago, was describing another variant of this, possibly of the same disorder that he called non-fluent aphasia. And in this case, patients had atrophy of not the perisylvian, I mean, in some ways, the anterior perisylvian cortex. And these patients were also thought not to have Alzheimer's disease, but when the first clinical pathological correlations came out, actually a lot of these patients had Alzheimer's disease. So this is where we started our research and trying to figure out the different variants and the different presentations of this disorder. And to add to the confusion, we describe another variant that is called the logopenic variant, in which atrophy was instead more posterior. And what we'll do today is go through the clinical symptoms that are associated with these three variants and the pathological changes and some new findings and new aspects of how we can use and study these patients also from a cognitive neuroscience perspective. After a few years of debate, these three variants were recognized as in an international criteria. I guess everybody agreed to disagree slightly, but use this kind of general nomenclature. And why is it relevant from a clinical point of view? Being a clinician, to me, is very important to do theoretically based research, but also do something that has direct implications for my patients' lives. And the interesting aspects is that these three disorders have different patterns of atrophy, but also have different pathological changes. And at the end, the treatment, the curative treatment for these disorders are going to be molecular in nature. So we want to predict from the clinical and anatomical changes in the brain, the pathology. And we're starting to have some biomarkers for some of the variants, but not all of them. So these three syndromes are associated with higher probability of different pathologies. So the logopenic variant is really an early age of onset Alzheimer's disease variant. And the other two, the semantic and non-fluent variants, are instead part of the FTD spectrum of disorders. So the molecular changes are very different in the brain, and the treatments will be very different. So we're not just doing a clinical exercise of what let's say, a physiology of distinguishing the symptoms very carefully. We also making a very different diagnosis that can have very different implications for treatment. I'm not going to go through this slide, but just to show you the complication of the FTD spectrum disorders. These two, the frontotemporal dementia spectrum disorder, of which the primary progressive aphasia are part of, different molecular changes, different genetic changes. So very relevant for us as cognitive neuroscientists to understand these disorders in detail. From a basic neuroscience perspective, what is most interesting to me is figuring out why these different disorders have different susceptibility for different brain networks. So why is it that in the non-fluent variant, the atrophy is more frontal, and in the early age of onset Alzheimer's, it's more temporoparietal? Why do these, each individual is susceptible to these different disorders, and how do they spread over time? And the model that we're using is that there is really, that these are really network-based disorders, and that there is a susceptibility of specific epicenters in the brain, just like the substantia nigra is susceptible to Parkinson's disease. The parietal lobe might be more susceptible to the amyloid or tau changes in Alzheimer's for some molecular genetic reasons that the basic scientists are studying in the lab. And then the disease spreads transsynaptically following the connectivity of the brain. So we can follow longitudinally these patients, and knowing the connectivity, we can kind of predict where the next change or the next symptoms will be. So in the model, we have epicenters and nodes of the disease. So the idea is that there is an intrinsic vulnerability of the specific epicenter for reasons that we don't know. And we'll go through some hypotheses: genetic development, environment, multilingualism might be important, lifetime brain usage. And so when the disease hits, the first region that will suffer is the epicenter. And then depending on the connectivity of that epicenter, the disease will spread over time. Taking this framework, we have a predictable spread of anatomy, and we can have a spectrum of presentation of the disorder depending on where the epicenter is within that susceptible network. Now, we're lucky in the language world. We've been doing a lot of studies, as you all know. The behavioral neurology and really cognitive science started with Broca, and we have a lot of models and knowledge on the language network, and that's one of the reasons why I was interested in it from the beginning. We have models that we can apply to patients, and we have well-versed techniques. This is a techniques that Vale and others have really pioneered in the lab of using intrinsic connectivity network fMRI. And even with 10 minutes of scanning at rest, we can really isolate these different networks in the brain that then we can study in patients. And of course, also the connectivity between these regions. So we've applied many of these techniques over the years to the different patients. Okay, so we start with the first one, the anterior temporal lobe network, and which is the network that is more susceptible to TDP-43 pathology, and it presents in the spectrum of the semantic dementias. And I like to use spectrum because, again, if you think that this is the large network that is involved, left and right-sided, depending on where the epicenter is within this network, patients can present slightly differently, but within the same kind of network and domain. The way that we've managed to isolate these different symptoms is really thinking of the cognitive mechanism behind it. Not just think of the symptoms like word finding, but really try to get at the cognitive mechanism of where the word finding problem is coming from. Is it a lexical retrieval problem? Is it a semantic problem? Or is it even a motor speech problem? Because patients come to us in the clinic and they say, I have trouble finding words. Or they might even say, I have a memory problem. And the skill of the behavioral neurologist or the cognitive scientist is to then investigate where that problem comes from, because the cognitive mechanism is what maps to the brain, not really the symptom. So semantic memory versus episodic memory, I don't need to, this is a slide more for behavioral neurologists than for cognitive scientists. But as you all know, it's part of long-term memory. And the real difference that you see in your everyday practice, even in the clinic, is that it's not linked, semantic memory is not linked to time and space and to an emotional autobiographical experiences. So knowing that a phone is a phone or how a phone looks like, we don't really know when we learn it. And it really doesn't have a huge autobiographical component in comparison to episodic memory. It's different from just in lexical semantics. So there is a difference between semantic and lexical semantics. So it's not just words, but it's also the semantic features associated with objects, sounds, and so it's more multimodal in nature. It was used to be described as completely multimodal. So kind of the abstract, Platonic abstract idea of the objects. We kind of moving away from that a little bit, and we'll talk about it a little bit later, but it's definitely not just an aphasia. It's not just words, but it's the conceptual knowledge behind the words. How do patients who have deficits in semantic memory present. They present with confrontation naming difficulties, striking out of the most clinically used test in the US is the Boston naming test, is 6 items. They might name 5 of them. So severe confrontation naming deficit, but it's not just the word retrieval. They have difficulties understanding the words, and also they have trouble identifying objects that correspond to the words. An interesting symptom that we'll go into a little bit more detail that is linked to a semantic memory problem is surface dyslexia. And there is a striking dissociation between this severe problem with understanding words and retrieving words and concepts and fluency. So this is a very different from Wernicke's, classic Wernicke's aphasia patients. And the description is very different. Grammar and phonology are spared, and motor speech is spared. Now, if you think about it, this area of the brain is very, it's very rarely hit in stroke by itself. So we started learning about this syndrome with herpes. Herpes encephalitis hits the anterior temporal lobe. Fortunately, we have a treatment for herpes, so we don't see patients with this severe deficit. And also autoimmune disorders, paraneoplastic diseases, they hit this area of the brain, and keep that in mind because that might help us understand actually the etiology. So there is an infection, autoimmune kind of mechanism that seems to be appearing in the etiology of this disease. Now, if we think about spreading, what happens over time with these patients, the first descriptions was patients really with left, and my imaging studies are always, sorry, I'm a bit neurocentric, so they're neurological conventions, so left is left and right is right. The original semantic dementia patients and most of the semantic patients described are more left than right. And but if you think of the connectivity of the temporal pole, there is the uncinate fasciculus. So kind of over time, these patients become more behavioral, not just aphasic, but also they develop behavioral symptoms. So I have some video examples for you. This is a picture description task. And remember, these patients are very fluent, preserved grammar. What you'll might notice in this description is the lack of content words or noun, which is typical in these patients with a huge familiarity and prototypicality effect. So if you're examining them in the office and you just show them the usual watch or glasses, they might not know the name, but they will show you how to use it. But for less frequent items, they'll have a lot of difficulties. And this was part of the confusion between the US group and the UK group. If you use items that are in tests that are constructed for stroke patients, these patients are actually milder to start with, and they might do well and they might seem aphasic. But in reality, if you test them with less frequent and familiar objects, then the semantic, the multimodal semantic problem becomes evident.
So can I ask you please to tell me what you see in this picture and try to speak in sentences, please.
Well, this is a nice thing where I would be, right there on the water. That's a nice one. And of course, obviously, there are people who are just really seem to be enjoying it there. And they live there, at least temporarily. They don't probably live there, but they just like to go there. And this guy and girl, they're having a lot of fun together. And obviously there's some dogs, and there's some interesting people flying around down there. I like to do that one too. That's nice.
So again, not many nouns, not specific, a lot of verbs, a lot of function words. So you can almost visualize how these patients are compensating from that ventral atrophy with uses a more dorsal phonological and grammatical network. I don't have the same patient to show you, but here is an example of how they'll perform in a confrontation naming task, in which they have, again, very prototypical, typical symptoms of basically using supraordinate responses. So they have semantic paraphasias, but very specific. A patient with semantic dementia will never call a rabbit a frog. It will always call the rabbit an animal. So they have this prototypicality effect. So you can imagine a semantic network in which features become less connected and disintegrate. And what remains is the prototype of that category.
Is that vegetable, fruit, dog? I don't know what that is. Can? Cat? Is that vegetable, fruit, dog? I don't know what that
So
is.
basically, the only item that she really says, I don't know what it is this less.
Can?
It's less frequent. And the others, she's always giving the supra.
Cat?
Single word comprehension is very typical. It's something that you never forget if you see it once. It's patient that is so fluent and they're telling you about some story in their own life. And then all of a sudden you say a word that is out of context that they're not used to. And they go, I should know that. What is that? What does that mean?
Over, and if you need flowers with somebody or something for presents, come on over and I'll give. Okay, now what's this?
Take a look at that picture and tell me what you see and try and talk in sentences.
Try to talk what?
In sentences.
What are sentences? See how stupid I am.
Just to talk.
They say, oh,
Can you point to the cup for me?
Is that this one?
Okay.
No.
Matches?
See what this one matches.
Can you point?
I think this gives you an idea of the striking dissociation of the language functions in these patients. Now, surface dyslexia is a very interesting symptom that kind of starts giving us an idea of how important it is to think about the patient's native language, the typology of the language, on how these patients present, and also on how we write the criteria. And we'll talk about it a little more later, but most of these diseases have been studied in English-speaking patients. And so the criteria that we wrote match the typology of the English language and might not really work in patients who are multilingual or native speakers of languages that use different type of codes. So surface dyslexia is a typical symptom in English, also in Japanese, actually, and is a difficulty that these patients have in reading low-frequency exception words. And I'll show you an example, and then we'll talk about it more.
Bury, yacht, flannel, tail, wolf, Iceland, wedding, chicken, colonel. What is colonel?
Nerve, Sue, sword, shoe.
So for an Italian like me, these patients finally read how these words should be read, right? You read yacht. Why in the world should that be yacht? So basically the word form of yacht seems to be part of a semantic network. So these patients that lose semantic memory lose this word form, but they can still use the phonological rule. And so what we say is they regularize, they make these predictable errors. So if we think in general terms, there are two routes for reading, the sublexical route and the lexical route. These patients have a spared or relatively spared sublexical route, and so they are able to read pseudo words and words that have regular spelling patterns. Now, all the words in Italian are regular words that you can read with sublexical routes. Not all, but almost. So these symptoms in Italian doesn't really exist. It only exists for exception accentation. So whether you say ancora or ancora in Italian depends on context, and that's the only error that these patients really make in reading and writing. In a logographic language like Chinese, the dyslexia and dysgraphia can really be the first symptom of these patients because the language stresses that mechanism. And here comes the great studies that Vale did when she was with us in San Francisco, an MEG study looking at the temporal dynamics and of these particularly clear symptom that these patients have. And it's not easy, it's not often that we can actually look at patients in the scanner while they make errors that are predictable. So this is a phenomenon that really we took advantage of. And Vale was able to show that these patients overactivate the dorsal route to the dorsal sublexical route. So it also helped us start to think about these disorders not just as impairments, but also think of, since they develop over time, at what compensatory mechanisms we can take advantage of. So this was really the experiment to look at how these patients can perform these tasks in this anomalous way. And it was interesting because from a behavioral point of view, they performed in a predictable way. So Vale can show you in another time the details of the experiment, but it was really clear that these patients activated this dorsal parietal region that we would expect in a sublexical route even more than controls, and only when they were reading pseudo words and not regular words. We use this kind of paradigm to, again, look at increased connectivity, and we can't really call it compensation, but increased recruitment of networks that are not degenerating, and see how they can be even associated with emerging talents in some of these patients. So this dorsal route in patients with semantic dementia is involved in irregular word reading, but also in the increased articulation rate. You heard in the example of the patient I gave you, they speak really fast. And so how fast they speak is associated with connectivity in this dorsal network. Another experiment that Vale conducted showed that they have increased activation of visual areas while they do semantic association tasks that they can still do. So they're probably overusing a visual strategy. And that has been shown to be associated with increased visual creativity in these patients during a specific time point in their life, in their disease course, in which probably they're just starting to have atrophy, but it's not so much to cause a deficit. In that particular moment, there can be this increased creativity and visual production. Okay, so we talked a lot about patients with left anterior temporal atrophy. An active area of research that we're really interested in now is patients with right anterior temporal atrophy. And they have a specific semantic impairment that we think is related to visual and emotional stimuli. And we didn't used to see them much because they don't present with an aphasia, they present with altered behavior. And really, I think in the studying of behavior, we're a little behind the study of language in the sense that we're just starting to create some specific models. And so we kind of calling them, at least in the neurology world, behavioral changes, but they can be very different. There can be slight disinhibition, there can be slight loss of empathy, a little bit like word finding problems can have different mechanism behind it. The behaving in an unexpected way or a change in behavior can have many different reasons. And so these patients usually present to psychiatrists or counselor. And many times couples therapy. These diseases start early in usually early 50s. So someone changes personality, a way to interact with others is really not thought as a neurological problem, is thought more to be a psychiatric or psychological problem. So when do they arrive to us neurologists? And when they start having trouble finding words. But actually, when we looked at our whole cohort, 40% of the patients that presented with semantic dementia actually had more right-sided atrophy than left. And we started studying these patients with in more detail. We don't quite have a consensus diagnosis yet. We're just starting. But how they seem to present is really with a loss of empathy, but a loss of empathy that is caused by deficits in semantic processing of emotional stimuli. They have a hard time understanding concepts that have to do with emotions. So the difference between anger and disgust, just like they had trouble distinguishing the rabbit from the frog, is not really the general category of positive or negative emotions they have trouble with. They have more difficulty in the granularity of features associated with the specific emotions. So they behave weirdly, but they behave weirdly because they really do not understand the subtlety of the emotional changes around them. At the same time, they have trouble recognizing famous people. Famous people at the end, familiar people, are very linked to emotions and social emotional functioning. So probably the two are related. And they also have these rigid, repetitive, ritualistic behaviors that we really studying that we think might have something to do with the fact that they become less interested in people. And so they become more interested in the world around them. Typically, they become interested in mysticisms, in religion, in the connection with the world, more than the connection between actual people. Another study that Vale did in San Francisco was really looking at the different aspects of famous face and familiar face processing in these patients with the right-sided atrophy, anterior temporal. So it's not really linked to the FFA or the more visual areas. It's more a deficit recognizing famous people. But the left-sided patients have a lot of trouble with recognizing famous people too. The right-sided patient seems to have this difficulty in this task particularly, in which they kind of have to implicitly point to the famous person within an area of faces that are similar visually. And this is where they really have trouble. While the left temporal patients, even if they don't know who the person is or their name, they will be able to point to it. So very specific deficit again. Other tasks that we are constructing really to look at the semantic relations of emotional stimuli to identify more right anterior temporal patients early on. And this is an example in which you have to match the top face with the one of the items below. We talked about evolution. Think about connectivity. The anterior temporal lobe is either connected to more posterior regions or to frontal regions. These patients often develop behavioral symptoms later on.
The thing I'd like you to do is raise your hand.
Okay. Mm-hmm. You want me to do?
That's good. And shut your eyes.
Try.
Example. Okay, from the pathological point of view, this is actually the brain. Many of our patients, we're fortunate to have a brain bank in the same building where we see patients. There's really a lot of collaborations between basic scientists and clinical scientists. It's quite emotional to be called upstairs because one of the brains of a patient that you followed for 10 years is actually being delivered, and you can look at it and study it from a molecular point of view. And this was actually the man that you saw describing the picture. Part of the disease was that unfortunately he developed a compulsion for drinking alcohol. And so he died early in the disease course of acute pancreatitis. And you can really see in his brain the focal anterior temporal atrophy and the sparing of the more posterior and anterior region. Back then, when this happened, it was 2004. He was one of the first patients for which that I had followed, that I actually looked at the pathology together with the pathologist. And to tell you how the science of these diseases evolved, back then it was classified as dementia lacking distinctive histopathology, meaning that we didn't know what these inclusions were made of. All that we saw were these like holes in the cortex, these little white spongiform changes, but these we didn't know what they were. And in 2004, for the first time, ubiquitin was discovered, and then TDP, and now we classify these patients as having FTLD, TDPC pathology, very different from early onset Alzheimer's disease or from a tauopathy. And now that we identify them, hopefully we'll find treatment for them, just as we have found for, starting to find for Alzheimer's disease. Right and left temporal variance is the same pathology, TDPC. So it's really important to identify those patients with right anterior temporal atrophy, because it really helps us diagnose the patients from a biological point of view. There is no biomarker for these diseases yet, so the clinical picture is really what is telling us what the disorder is at a molecular level. Okay, now we change course completely. It used to be the same disease. It's a completely another disease. We're talking about the logopenic variant, and I hope I'll convince you, and this was really the work that we did a lot, it was isolate this variant from the FTD spectrum disorders. This is an atypical variant of Alzheimer's disease, and these patients are young. They start really in their 50s, and they are great candidates for the new therapies, anti-amyloid therapies for Alzheimer's disease. Now we also have biomarkers in the blood, in the CSF, for tau PET, that we can identify amyloid and tau in the brain. But when we first started, these were not available yet. And actually, this was one of the first models in which we tested the sensitivity of the amyloid PET for Alzheimer's disease, because these patients really presented with a syndrome that was thought to be FTD, but it ended up being AD. And these were the cases that were initially diagnosed as non-fluent. And so it was the reason why the cohorts of non-fluents had 30% of AD pathology. So how do they present? They present with an intermediate level of fluency, and they have impaired single word retrieval, but it's not caused by a semantic memory impairment. It's actually caused by a phonological impairment. So when you actually go and investigate the cognitive mechanism underlying this word finding, is completely different, as you would expect from the anatomical distribution of atrophy, which is really posterior temporal parietal. Motor speech is spared, although these patients make errors in spontaneous speech that can be difficult to distinguish from motor speech errors in English. In Chinese is a whole other story, but in English, phonological paraphasia and distortions due to motor speech errors can be difficult to distinguish, if not for speech pathologists who really are trained perceptually to distinguish these errors. Semantics are actually spared, so they might have trouble naming items, but they know what the objects are. And when we look at molecular imaging with PET and tau, we can see that amyloid, PET, and tau are the two proteins that deposit in Alzheimer's disease. PET is really diffuse. Amyloid PET shows diffuse positivity. What really correlates with the clinical syndrome is the tau. So examples, the most prototypical deficit that these patients have is a difficulty repeating. They have phonological impairments, phonological short-term memory impairment. And so they have trouble repeating sentences and pseudo words verbatim. They understand the meaning, but they have trouble repeating them exactly. So again, there is a very important effect of length and let's say prototypicality of the sentence in this case.
Bed,
Bed,
nose,
nose,
pipe,
pipe,
window,
window,
banana,
banana,
snowball.
snowball.
The telephone is ringing.
The telephone is ringing.
He is not coming back.
He is not coming back.
The pastry cook was elated.
The pastries person was delighted. So
The telephone is ringing, you hear, there is not many, you understand it, there is not many other ways to say that sentence. The pastry cook was elated is an unusual sentence. It's easier to say a happy baker. And so there she loses the trace and starts making errors. You can imagine these were actually the patients first described by Marcel Mesulam, so you can understand why he thought they didn't have Alzheimer's disease. How can, this is a very young person that has this mild language problems. It's very hard to hypothesize that they might have Alzheimer's disease.
Bed,
Bed,
nose,
nose,
pipe,
pipe,
window,
window,
banana,
banana,
snowball.
snowball.
The telephone is ringing.
The telephone is ringing.
He is not coming back.
He is not coming back.
The pastry cook was elated.
The pastry cook was elated.
Okay, good.
Okay, so is that those are the typical errors? Is that a phonological errors? Is that a mode of speech error? I think now that we know, we can say that is a phonological errors, but sometimes they're hard to distinguish, and that's why these patients were classified as having the non-fluent variant. When we look at more specifically designed sentences and words to look at phonological short-term memory disorders, we see that the atrophy, the most severe the deficit, the more they have atrophy in this network here. Of course, we know that the inferior parietal lobe is kind of a hub of many different functions. And so since the vulnerability of this area to Alzheimer's disease is not specific to the single region, is specific to this whole network, patients can present with other items, other difficulties. And for instance, they can be dyscalculic, and often they are apraxic. They present more as language problems, but they might have these associated difficulties. And actually, even in the early descriptions from Marcel Mesulam, dyscalculia and dysgraphia were the only other deficits that were admitted in the primary progressive aphasia description. But following many patients and looking at specific epicenters in specific areas will help us understand this syndrome more as a spectrum in which we can have more deficits in phonological processing or more deficits more in attentional and short-term memory difficulties. Of course, I'm studying more the left-sided of the brain, but as we were talking about this morning, there is a variant of early onset Alzheimer's disease that has similar vulnerability, but more in the right hemisphere. And these patients have a lot of difficulty with visual construction and visual spatial attention. One of the first studies in amyloid PET showed that these patients had amyloid positivity from a kind of molecular disease point of view, and that this positivity was not due to age. So many amyloid positivity, amyloid deposition in the brain is increases even in neurotypical healthy individuals with age, and it might not lead to Alzheimer's disease. That's why we always have to correlate clinical with these imaging findings. But in the patients with the logopenic variant, it was not correlated with age. In the other two variants, it was, meaning that probably in the other variants, when we see amyloid positivity, it might be a co-occurring pathology due to age. Now, why do these patients with Alzheimer's disease present so atypically? You know, this gets to our idea of vulnerability. Why are these areas so vulnerable to Alzheimer's disease that these patients will have symptoms when they're in their 50s? One of the aspects, definitely not the only, but one of the aspects that we noticed interviewing these patients is that many of them had a history of neurodevelopmental language difficulties. Both of those patients that you saw in the videos, both had children with dyslexia, and thinking back, they realized that they had dyslexia as well, but they were not diagnosed or identified because it just didn't happen at that time. And if we think about the network involved in dyslexia, is a very similar network. So one of the aspects that we've been studying, and that's why I was so crazy to also open a dyslexia center so that we can see families and patients across the lifespan, was to really show, and this was even a retrospective study that my colleague Zach Miller did, and showing a very high unexpected incidence of dyslexia in our patients only with the logopenic variant, indicating that probably there is a network susceptibility, a network specific susceptibility that can have repercussion across the lifespan. So individuals with dyslexia or ADHD or on the autism spectrum might have a network susceptibility that gets compensated during a lifetime. It might even get forgotten about. And then a disease of adulthood happens, a stroke or a neurodegenerative condition, and it might present differently than it would have. So we really learn to take very extensive histories of cognitive and brain health across the lifespan. Now, is there really a common molecular mechanism? Of course, dyslexia is much more common than logopenic PPA. It's not that every patient with dyslexia will get logopenic PPA, but if a patient or an individual with dyslexia happens to have a vulnerability also for Alzheimer's disease, it might start earlier and have a longer course and present differently. And we do think is network specific. So of course, when developmentally a more frontal network is involved, stuttering or ADHD, then it might create a vulnerability for presentation of a disorder that is of adulthood that hits that disorder too. And it's something that, for instance, even in rehabilitation of stroke, we've never looked at. Maybe some of the patients that don't respond to rehabilitation after a stroke might have had a history of a neurodevelopmental condition, and we should have actually approached rehabilitation in a different way. In many of these patients, the disease course is very long. There is a progressive aphasia, isolated progressive aphasia stage that lasts for many, many years. Because unfortunately, the progression is that the disease spreads and these patients become more cognitively impaired. But when they start this early and just with the language of short-term verbal memory impairment, actually the disease might have a slow and long course. Variability of tau deposition within the network will cause differences, again, in the clinical presentation within a spectrum. And the neuropathological studies that we are doing in these patients, especially when they also have the neurodevelopmental history, I think is actually going to inform us on the neurobiological origin of dyslexia as well, of which we really don't know much. So in this case, for instance, you see these neurons here that are very enlarged and doing genetic expression and specific studies really show that these are neurons that are not in the layers of the cortex where they should be. So they they migrated in a different layer of the cortex, which we think is one of the mechanisms in neurodevelopmental changes. And maybe these different milieu than they're supposed to be makes them more vulnerable to early symptoms of neurodegenerative pathology. But this is an active line of research that we are conducting right now. Many of patients with FTD actually have genetic autosomal dominant forms of the disease. And in this case, we're studying all the generations, starting with young children in the families. Okay, quickly, just a presentation of the non-fluent variant. Yeah, sure. This one is the most similar to, I would say, Broca's aphasia, motor speech difficulties, and agrammatism. I'm not going to show you the video, but there is a lot of debate in the literature whether there are different presentations. Some patients present more with motor speech impairments, some with agrammatism. Most have both. Again, probably in relation to the specific areas and epicenter within a widespread network involved in this disorder that is really centered in left frontal networks. In these disorders, we also, in this variant, we see very clearly the typological differences between languages as well. So English has more articulatory complex, a lot of consonant clusters that can manifest with the motor speech errors. In Italian, grammar is more complicated. So non-fluent patients in Italian present more with grammatical problems. In English, more with motor speech difficulties. Chinese is a tonal language. It's very difficult from an articulatory point of view. So many of patients in Chinese also present more with motor speech difficulties. We're using a lot of automated techniques now to isolate some of these symptoms and hopefully make the diagnosis of these patients more scalable and less linked to specific expertise of very trained clinicians. Pathologically, you can see an example of a non-fluent case. You can see the atrophy very limited to this premotor posterior Broca's area and highly connected to SMA and pre-SMA. You can probably see the atrophy there by kind of this changing shape of the dorsal cortex. The pathologies, FTD tau, very different from FTD TDP. If we put them all together, we'll never find a treatment for these disorders. So very important to distinguish them, and not 100%, but highly predictable. Because of the fact that PPA is being studied mainly in English, we're realizing that many patients across the world are not getting diagnosed and are not getting access to treatment. So we put together this network of scientists and studying these disorders in all different languages. You are particularly in a particularly multilingual environment, and it would be super interesting to really see how patients switch code between the different languages. Thank you. I know 3 disorders is a lot. Thank you for your attention. I just wanted to thank all the team at UCSF. When I first moved there in 2001, we were this little group, and now is a huge group. I would have never thought that I would stay there for 24 years, but it happened, and it's been an incredible journey and an incredible environment to really follow scientific and clinical passion. And I'm really happy that I had the chance of having both Vale and Abigail in the lab, and looking forward to continuing to see your success. Thank you.